So for today's session on telehealth, I know, like you, many of us have newfound experience with telehealth. I know that all of my family's appointments have been via telehealth since March 2020. So this is a particularly relevant session today. We will have an overview of telehealth for children and youth with special healthcare needs. We will hear what families are saying about their experience and discuss gaps, policy initiatives to address those gaps and how you can get involved. And you should come away with some specific action items and ways to relate your experiences, especially in advocacy. For our speakers today, we have three wonderful speakers. First, we'll have Nancy Netherland. She's a parent advocate with two former foster children living with rare chronic medical conditions. And Nancy is the founder of Kids and Caregivers, and they provide families, caregivers, and providers with support, resources, and information. Her full bio is on Whova, where you can see that. She's going to share her personal experiences using telehealth for her children's care. We will then have Dr. James Marcin. He's a professor of pediatric critical care at UC Davis School of Medicine and the director of the Center for Health and Technology at UC Davis. He will share a perspective from provider standpoint. He'll discuss the benefits, the barriers to telehealth care, especially for rural communities. And then we will have Gabriella Barbosa. She's the managing director of policy for the Children's Partnership. And she's an attorney, a former teacher, and she has served as public policy director for local elected official and for a nonprofit. She's going to share findings from her organization's telehealth research project and outline ways for families to get involved, and also talk about what lawmakers need to understand from families. So we will go ahead and get started with Nancy.
Thank you so much. It's a pleasure to be here today, and I'm delighted to be sharing a panel with Gabriella and Dr. Marcin. So my name is Nancy Netherland, and I'm the mom of two kids who live with medical complexities. I'm going to attempt to share my screen. Great. Sorry, I'm going to not share screens. So sorry about that. Okay, well, anyway, I am about to share my screen in a moment, but I have two kids who are former foster kids with medical complexities. And I like to talk about telehealth in terms of what it's meant for their childhood and living as young people who have a lot of medical appointments. I'm going to try this again. Okay, that should be up now. I'm sorry, you guys, I'm gonna stop trying this. Okay, so anyway, I'm the mom of two kids, Sarah and Amelia. Amelia lives with a multisystemic illness that requires a lot of medical care. She has 20 specialists, and that has meant that she has anywhere, we figured out at one point that she had 4 to 5 medical appointments per week. That doesn't account anything for her IEP. So she has occupational therapy, palliative care and pain management, physical therapy, psychotherapy, and then she has also infusions that happen every 3 to 4 weeks. So she's got a heavy load. So before COVID, we allocated about 17 and a half hours per week for her medical care. And that was all during the hours of 9 to 5, if you will, because that's when the medical center was open. So we were carving time out of her school day. And we were also carving time out of her, sorry guys, I'm gonna try one more time to share my slides. We were also carving time out of her, I'm sorry about this, but I'm going to try to get this up because there are some graphics to go with this. It's just going to be less than perfect. So anyway, okay. So my kind of question with this is if you could give your kids an extra 5 or 10 or 15 hours a week of childhood, would you? And of course you would. And I apologize for the bumpy beginning on this. Really quickly, here is a little bit of an overview of a care map for Amelia, and a shout out to Packard for that beautiful design. But Amelia's got a huge number of specialists. She also has regular labs, radiology, oral medicine. And the reality was, before COVID, we were doing this all in person. It was the only choice we had, especially with her being on Medi-Cal. So just to give you some estimates, and this is very fresh in my mind because we just spent 2 days at the medical center, Monday and Tuesday. So a couple hours round trip, even though we lived very close to the medical center. Waiting times conservatively 45 minutes, though being realistic, our cycle times often ran to an hour and a half to 2 hours. And then appointment and follow-up, sitting, being roomed, waiting for paperwork, another 45 minutes. So we really had to carve out about 4 hours every time we planned on going in for a medical appointment, which was substantial. So I did a little bit of estimating, and both my kids have medical complexities. And for Amelia, at one point, we were spending about 17 and a half hours per week at the medical center. And what I realized is that a lot of the time we spent at the medical center wasn't actually time that we needed face-to-face with the provider. It was a lot of stuff that was really superfluous. I mean, I know it's important for billing and authorizations and all that kind of stuff, but in terms of my kids' perspective, it really wasn't necessary. And I will say that it also made it really challenging. You take a kid who doesn't feel well, my daughter's neurodivergent, and have her wait a couple of hours to see a doctor. It's not always a super big success by the time the provider gets in the room. So with COVID, and the public health emergency, we were able to really move to doing a significant amount of telehealth. And so the things that have made a huge difference is we've been able to eliminate travel times. We've been able to minimize wait times. Amelia has a fairly high medical trauma burden. And her anxiety around going to the medical center, she's been inpatient a fair amount, has had some hard times, is substantial. So it increases her comfort. It definitely reduces a financial burden. As I was, thinking about the number of hours of work missed yesterday and the cost of parking, the cost of buying meals, it's expensive having a child with medical complexities. It's expensive to go in for care. And also we regain lost time. It also removes geographic restrictions. We'd always wanted to live outside of the city, but because of Amelia's healthcare needs, had really felt like we had to stay close to a major urban hospital, even though what we really love to do is be in the country and ride horses, et cetera, et cetera. And with telehealth, we've been able to make that kind of a move. We've been able to move away from being so bound by geography to really being able to get her care for the most part anywhere. We still go in. I mean, we still have, she still has infusions, she still has labs, but it's really pretty minimal. It's a couple times a month as opposed to a couple times a week. I also think that something that gets lost sometimes with providing care is we forget that these same kids who live with medical complexities also usually have additional services. So her IEP is really substantial and very important. And we were losing, anywhere from 30 to 50% of her IEP services for outpatient care prior to having more expanded telehealth. So that has been substantial. I was playing with the numbers, and I think that we've recovered between 12 and 14 hours a week of childhood. And I mean, I really put it that way. And you know what we're doing instead of sitting in waiting rooms? And also, it's not awesome sitting in waiting rooms. I try not to be a complainer, but my daughter's on immunosuppressants. So even before COVID, hanging out in a crowded waiting room for 2 to 3 hours with people who bring their entire families, understandably, I've done it too, was not optimal, right? So there are a lot of reasons why it wasn't great, but we take those 12 to 14 hours. So she gets to go to school. She doesn't miss as much school, which is huge. She doesn't miss as many birthday parties and other things. And her love is horseback riding and equine therapy. And so we spend, I was thinking about the other day, I was like, how do I have all this time now to spend 5 to 6 hours a week on the ranch, watching my daughter, even when she feels crummy, just completely engaged with something she loves. And I realized it's because we're not spending that time in waiting rooms at the medical center. And I will say her team is really accessible. One thing that is important to me about Amelia's care is that we have the option of in-person care as well That's telehealth. And what this it's an extension of how her providers treat her. And I really appreciate the fact that her providers are making the decision with me about what's most appropriate. She developed some neurological symptoms, and we were able to go right into the medical center and spend time face-to-face with her neurologist. So I think that as I've been working and doing some policy work as well as being a mom on this. And one of my concerns that I have about some of the policy is that there are some discussions of addressing network inadequacies or having third party or standalone telehealth. And as a mom, what I have to say is I love that it's a continuum of care. And I love that I can follow up 5 appointments via telehealth with her rheumatologist with the face-to-face and ultrasounds of her joints if I need to. I will also say that telehealth has allowed Amelia to share more of who she is with her providers. We rescued a Mexican hairless street dog years ago, and she now brings Stella to all of her appointments. And Stella has proven to be an incredible therapeutic tool and a touch point when we see doctors in person, because they've all spent time with Stella. She's quite notable. The other thing that I like about this is that I think telehealth is allowing a child who's had a fairly medicalized childhood to really spend more time in the magic of childhood. And so she's spending less time in medical centers and more time doing things like riding her bike and riding horses. So I appreciate telehealth because there's more time for her to be out in the world being a kid and exploring while still getting really exemplary care. And that is not Stella. That is another dog that has hair. But our dogs do participate fully in all of our appointments. And I will say another piece, since I was not able to pull up my slide quite how I wanted to, and I don't have all my notes, is that one of the things that's been hard for us is our medical center doesn't have case management, and Medicaid doesn't reimburse for complex care management in the way that really would best serve Amelia. And so with telehealth, we've been able to get specialists. So without having to elevate or escalate to a family meeting, we're able to get specialists in the same room because the timing works better for them. So it's been huge because she's got a condition where she needs there are 4 specialists that need to interact with each other. And through no one's fault, the system is not structured to let them be in the same room at the same time. But with telehealth, it's been remarkable. It's really extraordinary. And when I talk to them, because I'll say, how is it for you? And they're like, oh, it's so much easier to be able to have the same kid presenting the same symptoms and have us all be in the room and be able to talk with each other and with her at the same time. And so she really is getting a whole person care through telehealth that I think didn't exist prior to that time. So I'm going to say thank you and apologize. You would think at this point in the pandemic and Zoom, I would have it down to share my slides, but apparently not. So thank you for your patience with that. And I'm going to pass it over to Dr. Marcin.
All right. Thank you very much, Nancy. That was wonderful. Let me pull up. Hopefully I will get this here, right? So again, thank you very much, everybody, for the opportunity to speak today at this conference. It's an amazing group of people doing amazing and wonderful work, and just to God bless you all and acknowledge the amazing work that you're doing here. I work in the pediatric intensive care unit at UC Davis, and I work with a team on telehealth services for the health system, so for children and for adults. And I've been doing it for quite some time. And pre-pandemic, we've always considered a lot of opportunities or advantages that telehealth can bring. And Nancy highlighted many of those. Thank you very much, in particular from the patient perspective. As a healthcare system, we have always seen telehealth as an opportunity to address barriers in access, those that live far away, or even if they're physically close, the work that's involved in moving them if they have, and their children, if they have to take public transportation, provider shortages because we're all very regionalized in big cities. There aren't the specialty services that are available in the rural areas. And we've always seen telehealth to be as a great way to address this. I'll talk a little bit about this later, and Gabriella is going to talk a little bit more. There are still lots of opportunities. since COVID has happened, we still realize that it's not the panacea or the great solution for access, because there's still lots of things that can't be done over telemedicine. And there are still lots of people that have difficulty accessing the technology, both because of physical issues, let's say without broadband or the appropriate device, but also the healthcare systems really has to step up their game in giving translation services, as an example, because it takes thought and more effort to be able to make this work and increase access. The other component, again, Nancy mentioned this, is the experience of care or satisfaction of care from both the patient and the family's providers. Again, Nancy had mentioned that telehealth can improve this experience to care. And there's also effectiveness of care. Sometimes when providers are talking to themselves, it's easier over video or care coordination. And again, Nancy, thanks so much. You really did 80% of my talk, which is fantastic and from a wonderful perspective. But in certain circumstances, telehealth improve the effectiveness of care. Let's say if you need immediate access and don't have time to schedule or something like that, you might be able to prevent a visit to the emergency department, for example, if you're able to contact a nurse, a social worker, and get something or supplies that you might need for you or your child. And then there's also the potential for telehealth to reduce the costs of care and really bringing value. So, and that has to do not only with the parents that have to spend out-of-pocket money to travel, but also the healthcare provider, right? If our practice isn't using the office and the nurses and the room cleaning, that those hopefully cost savings can be passed on, such that overall we're saving healthcare dollars for everybody. This is what happened to the use of telehealth at UC Davis. That's where I work. And I'll start by saying that we were very well prepared for telemedicine before COVID hit. Many clinics, as you know, were not prepared, and they did not have the telehealth infrastructure, the apps, the videos. The doctors and nurses weren't trained on it. We were just doing that when COVID began. So we were fortunate, blessed to be able to position very much to telehealth. And you can see before the pandemic struck, we were just doing about 1% of all of our outpatient visits over video. And UC Davis Health does about 1 million ambulatory visits per year, adult and pediatrics. And then right away, we shot up to about 70% of our ambulatory encounters done over video. And you can see in the blue, a majority of what we're doing is connecting to our patients over video. The orange is those patients that are either because of patient preference, provider preference, technical issues like broadband or device where they have to use the telephone. But we believe video adds a lot more, and that's exactly as Nancy demonstrated. We wouldn't be able to see her daughter with her dog without the video, so it adds a lot. Other clinics have a majority of telephone encounters, and I'll note that we're trying to make things video capable more and more. The blips in this curve have to do with the different COVID surges. Right now, we've gone from about 70% of all ambulatory visits over video to about 15 to 20%. And it varies between specialties, as you can imagine. For behavioral mental health, that's a majority of telemedicine. For, let's say, sports medicine or physiatry, PM&R, probably a majority of those are done in person. So I want to talk to you how we, from a healthcare provider's perspective, can leverage telehealth, digital health, mobile health technologies to help better care for our patients. The first is connecting to your primary care and specialty care visits. And again, Nancy alluded to this. And it can be done directly to your home, or in many instances, if you live far away, it could be done to your primary care provider's office. We call those provider to provider encounters versus provider to patient when we connect to you in your home. And then there's also a growing use of telehealth in school-based clinics. I will note that this is increasing in California, but there are lots of legislative opportunities for us to be able to facilitate the use of telehealth in schools. That's where our kids are. That's where they have time. And it makes a lot of sense for kids where it's difficult to get to them to a clinic or a doctor's office, but to be able to provide care in schools. And I'm very familiar with lots of different states, and some states are doing a better job than we are in California. So again, I see this as an opportunity care. Telehealth, whether it's going to be directly to the home or to the primary care provider's office, can also be done urgently on demand, but it also can be a scheduled appointment as Nancy described. So when we do it to the home, I presume that a majority of you have experienced this. In the interest of time, I have a video here that is just basically from YouTube that folks are able to look up. If you look up a video visit, they can demonstrate how it works at home. I'm going to just skip that in the interest of time. But as Nancy mentioned, there's lots of advantages to the family and to the patient. Again, we realize that all care can't be delivered this way, right? If a provider wants to if a specialist wants to talk to the primary care provider, like, well, what is their current weight or their height, or, what's the dose of medication? And mom or dad or patient doesn't know that, it's not going to be the same quality of care that, let's say, you were in the patient's office, or if you're in another doctor's office, to be able to answer those questions. So again, this type of modality, provider to patient to their home, has exploded since the onset of COVID. And again, we're doing it about 20% of all of our ambulatory visits. The next one is, again, to the primary care's office. And I'm going to pause this here, but this was a California Telehealth Resource Center video where it showed how a specialist at a children's hospital connect to a primary care pediatrician or family practitioner or nurse practitioner in a remote community to be able to help them manage conditions such as seizure disorder, right? And so again, that's going to be more convenient for the parent, better care coordinator. The primary care provider is going to be educated on what the specialist is recommending, and it's a great team-based model of care using this. And again, so this is where a specialist is connecting to a primary care provider with the patient in their office. So that's kind of model 2. Another one, I mentioned this, is school-based care. Again, I would submit that California has lots of opportunities to do hopefully a better job at this in the near future. And we appreciate our colleagues that are working in the legislative arena to be able to advance these bills. But again, it can be done. There are places that, like, if your child is getting sick or not feeling good or stomach ache, rather than sending them right at home, they can get on a video conference call with a primary care provider to be able to determine whether or not the child needs to be sent home or just watched in the nurse's office. Health screenings, health education for asthma, teaching children and their peers on how to manage their asthma, things like that, anxiety. For those of you that have children that are in medical therapy units within the medical therapy program, UC Davis and now other children's hospitals are using video to connect to the medical therapy units, which are school-based programs where physical and occupational therapy, durable medical equipment is prescribed. And so on the right there is a picture of our Dr. Davidson, who's a pediatric physiatrist or pediatric PM&R doctor, seeing a child in a school-based clinic with the mom there by the side, but a physical therapy assisting Dr. Davidson in the evaluation and recommended treatment. Another, so again, that's kind of like a third model of care I wanted to talk to you about. Another one is kind of a little bit more passive, which is remote home monitoring. There are technologies now available. Let's say if your child, or if there's a child on the ventilator or needs a pulse oximeter all the time, child with diabetes, a glucometer, blood pressure cuff. baby with heart rate monitors, things like that. These can be collected. We all know about iWatches and things like that, Fitbits. This data can be collected and transferred to providers and screened. And if, let's say, a glucose number is out of whack, or if there's something going on with the oxygen of your child, that we might be able to better care and more proactively intervene if there are any issues in the care that way. I will say that this is just beginning to happen. Home monitoring, I absolutely think that it's a big part of the future of healthcare and the way that we deliver care and help monitor care. I really do think that it's going to ultimately lead to better patient care when we're doing this monitoring of patients, that it doesn't require a scheduled appointment with the provider. But the technology still have to be figured out. And of course, like everything, it's all about the almighty dollar, what gets paid for and how it's paid for to be able to try and keep your patients and children healthy at home. So barriers for patients. I think Nancy could also probably mention some of these as well. But again, clearly not everybody has broadband access. 56% of low-income Americans don't have good, reliable broadband at home, right? That's a real problem. And so we talk about these services, but if you live in an area that doesn't have good broadband access, this can't be used for you. Language barriers. Of course, being able to bring in an interpreter, let's say that's in the clinic, might be a little bit easier than it might be to get the operation set up to bring them into video assessment. Also, the health record in American law it's defined as being in English. So that's in the United States, medical records are in English, period. So there's a problem. And so everything that we can translate up until the medical record, like instructions on how to do the video visit, advertising so that those that don't speak English know that video visits and similar telehealth technologies are even available, has to be done. And then if there's a patient that's encountering home monitoring or something like that, we have to have translation services integrated and availability. Technology, awareness. Well, post-COVID, most people know about telemedicine, but again, there's still some folks that haven't been able to use it for a variety of reasons. And then there's not only are there barriers to the parents, as Nancy and others can lay out better than I, but there's also barriers for us providers, right? We are busy in general. There's not a lot of doctors or nurses that are sitting around going, gosh, I wish I could see more patients now. In general, we're overwhelmed. And so trying to have us adopt these technologies, integrate these technologies in the process flow, it's hard for us, just like it might be for everybody else. Sometimes it enhances our ability to engage family members over video if you see the whole family. Sometimes it limits that, where maybe people might come to an in-person visit, but they don't do it over video. There might be privacy issues with these types of technologies. For example, teenagers, there might not be a private place for them to discuss confidential medical issues. There's also the perception that it might be lower quality of care. This is important for CCS, payers, everybody, that, hey, we don't want you to use the cheap video way, but we want there to be in-person care. And so it's really dependent upon the patient's condition, the family, what they need to be able to make these decisions on when telehealth is appropriately used. And of course, on the doctors, the nurses, the therapists, the social worker side, everything, it comes down, we have to get paid for our services and our time. And currently during the public health emergency, while there is payment parity, we don't know if that's going to continue beyond the public health emergency. We hope so, we think so, but for these models of care to be adopted, there has to be appropriate payment. So what I'm hoping, what we're doing at UC Davis, what everybody is doing even in their own personal lives, is to reimagine how we both deliver care and receive care, right? Whether it's a provider to provider telehealth clinic, a direct to patient telehealth or provider to patient video visit, whether we're getting care in the school, whether we're doing remote patient monitoring technologies, or in person, right? We want to pick the right type of encounter for the right technology application, if that makes sense, right? So in some circumstances, a video visit direct to the home is great. In others, you have to go in person. Another might be a chat session with a provider on your smartphone. Another service might be at their school, but trying to be able to get all of that coordinated is certainly a goal that I know that the providers, as well as the patients and parents, are working for. That's the end of my talk. Thank you very, very much for your time, and I'm happy to take questions. I'll look at the chat. I'll mute.
Thank you, Dr. Marcin. I would like to note that 42% of our attendees today are parents or caregivers or other family members, and most of us can relate to the experiences that Nancy shared, especially her comments about accessing specialists and really the desire for choice between telehealth and in-person visits. She brought up some things also that aren't always mentioned, the cost to families, the opportunity for things like her daughter to share more about her life, or have her pet as our comfort item at the visit. And Dr. Marcin talked about the value of telehealth in improving quality, reducing cost to families and our system, and working with families, especially many of you who are doing a more high-level monitoring and home care. And I'm happy to see that 20% of our overall attendees are healthcare providers. They have the opportunity to hear the challenges that families are having. Nancy, would you like to take a few minutes to comment on what we heard from Dr. Marcin?
Yeah, I mean, I'm a big fan of Dr. Marcin's work and advocacy and telehealth. And I feel that one of the things that, so I am sitting, and this will, I think, be a nice, as Gabriella will speak more to what's happening policy-wise, and she's done some amazing work with input from users, families. But one of the things that Dr. Marcin has talked about is really what's appropriate for each patient and each provider. And I really think that is so key, and something that sometimes in the policy discussions is not always at the center, but that really that telehealth has offered. I mean, it's been huge for our family and what it offers. I embrace it. And I also, like Dr. Marcin, have some concerns that in our excitement for this new technology, that we don't lose sight of quality assurance measures, and that we keep guardrails up to make sure that providers and patients are really, as they do when they're in an exam room together, able to make decisions in the best interest of the patient and patient care. So that's something that I always appreciate. That I'm sorry, I got just texted. That's something I always appreciate that Dr. Marcin brings up. And I will say too that the power, I work and I live now in a rural community, and there is a profound shortage of providers here. And we literally we would not be able to be in a rural community were we not able to access Amelia's care. Recently, she got sick with COVID despite all of our best efforts. And the access to urgent specialty care without having to drive down to San Francisco from Nevada County was huge. And I don't want to exaggerate it. It wasn't life-saving, but it certainly made her access to care much quicker than it would have been where we'd have gone through a different pipeline. So I recognize that as a powerful tool. The other thing I will say is, as a parent of a child who's got a lot of different needs, extra needs, I feel like she's able to navigate her healthcare more effectively. And the other thing is, as she becomes a teenager, we've been able to use telehealth as a teaching tool in a lot of ways that we couldn't do in the clinic as well. So we're able to, there are ways that I can leave the room with telehealth so that she can have and practice one-on-one time with her provider in a way that is not as gracefully or easily executed in patient. It feels a lot different for me to walk out of a physical room when we're together, but when we're in a telehealth room, I can make an excuse to leave, which I've always cleared with her physicians. But anyway, I think there's some interesting opportunities for the developmental needs of kids. And I'm going to stop speaking because I know that Gabriella has done, we were speaking yesterday in a group together. So we sit on some panels. And Dr. Marcin as well, there's a panel for state of California telemedicine, looking at extending telemedicine beyond the public health emergency and looking at policies that will impact everyone, but also specifically families on Medicaid and Medi-Cal, which a lot of children with special health care needs are. And so there's some exciting work coming up and informing that, those efforts. So I'm going to pass it to Gabriella.
Thank you so much, Nancy and Dr. Marcin. I will quickly share my screen. All right, can you see my screen? Great, thanks everyone. Okay, so I'm going to go through my slides a little bit quickly here. So I'm Gabriella Barbosa. I'm the Managing Director of Policy at the Children's Partnership. We are a California-based advocacy organization dedicated to advancing child health equity for children of color and low-income children and children immigrant families through public policy, research, and community engagement. My personal background in history is, as you all heard, as a lawyer. Earlier on in my career, I represented English learner students, many of whom also had individualized education plans and special healthcare needs. I'm really focusing on ensuring that they had equal access to public education in California and Los Angeles specifically. So today I'm going to go through first giving a little bit of data on California's children, who they are, and also specifically on children of color who have special healthcare needs in California. I'll then quickly go over the telehealth policy landscape and what the opportunities are to get engaged right now for families. I'll then speak a little bit about telehealth equity and access issues that we've seen come through a couple of surveys that we had distributed across California with a couple of partners. I'll talk a little bit about a current research project that we have around right now, specifically engaging families of color who have children with special healthcare needs in telehealth policy advocacy. And then I'll end by talking a little bit about why policymakers and decision makers should involve families in telehealth policy research and advocacy. So just really quickly about who California's children are. So California's children are a very diverse population of kids. We have about 9 million kids who live in California who are under the age of 18. 75% of those kids are children of color. They are Latinx, Black, Asian American, or Native American. The biggest group of children in California are Latinx children, who make up slightly over half of our state's population under 18. So now getting a little bit deeper into specifically data on children who have special healthcare needs in California. These children are also very diverse in California. About 14% of kids under the age of 18, or about 1 million children in California, have special healthcare needs. And of these children, about 2 in 3 are children of color. That is, they are Latinx, Black, or listed in a group called Other, which also includes Native American children and children who are mixed race. So you'll see I listed some of those data points on this slide here. Unfortunately, we don't have really specific statewide data in California about Native American children who have special health care needs in our state, likely due to issues around racial misclassification or low numbers or being placed in the other category. But in a national report that I was able to find from 2001 that did have the numbers, at least nationally, of Native American children with special health care needs, it's about 1 in 5, or 17% of Native American children who have special health care needs across the United States. And this was actually the highest rate across all races and ethnicities. So it's important to also, center these children in these conversations as well. So just quickly, a little bit about what the telehealth policy landscape actually looks like for families to get involved. So as you heard from both Dr. Marcin and Nancy, since the onset of the COVID-19 pandemic, healthcare has really become increasingly connected through telehealth. Because of shelter-at-home orders that required families and children to stay at home, the need for telehealth to access care obviously became even more important and apparent early on in the pandemic. And there have been temporary policy changes that have been able to reduce barriers to telehealth access and have promoted the use of telehealth as a way to deliver acute, chronic, primary, and specialty care. And in California, as a result of the public health emergency, our Department of Healthcare Services implemented additional broad policy flexibilities specifically for patients in Medi-Cal relative to telehealth in order to meet the healthcare needs of its 12 million beneficiaries, over 5 million of whom are children and youth. And prior to the pandemic, Medi-Cal really restricted coverage for telehealth to live video and asynchronous telehealth services while excluding audio-only services, e-consults, and remote patient monitoring. Previous policy also limited the location that patients could receive telehealth services, excluding them from being able to receive care in their own homes. But with the declaration of the public health emergency, our Department of Healthcare Services was able to implement, with authorization from our federal government, increased policy flexibilities around the ability to use telehealth, and included the coverage of audio-only services, lifted location restrictions so patients could communicate with their providers from their home, and also specifically increased flexibilities from community health clinics. So those patients could receive care using various telehealth modalities that was most accessible and convenient to them. And we really see, as an advocacy organization, this process as an important opportunity to ensure that telehealth is accessible to all. As Nancy mentioned, right now what's going on in the state is essentially we have these temporary policies because of the public health emergency, but the state is convening a group of stakeholders to essentially provide recommendations and feedback about which of those temporary telehealth policies should become permanent. And really looking for an eye towards those policies that increase access and equity among Medi-Cal patients. So again, the Children's Partnership is an advocacy organization dedicated to advancing child health equity. We really see this as an important opportunity for us to really uplift the experiences that families have been having utilizing telehealth in the last year and a half, and their own recommendations around telehealth policies. And so we've actually been partnering in this last couple of years since the pandemic began with several different organizations to survey families across California about healthcare access and about the utilization of telehealth. And then separately, we've also been convening families through listening sessions in a research project where we've been engaging with families in 3 different regions of California directly to hear their experiences and thoughts around telehealth, and specifically families of color who have children with special healthcare needs. So these 2 surveys that we were able to distribute in the last couple of years really highlighted for us telehealth equity and access issues during the pandemic. We partnered, for example, on one with an organization called the Parent Institute for Quality Education, which some families who are attending here today might know about and might actually be involved with already. This is a statewide parent advocacy organization that's really dedicated to working with parents of English learner students and immigrant families. And so we partnered with PK on a community needs assessment in the fall of 2020 of over 1,300 monolingual Spanish-speaking families across our state with children in public schools. And some of the questions that we added specifically sought to understand whether these families had the necessary tools to access health and mental health services for their children using telehealth during the pandemic. And we found that families are not and are facing different access issues. We found that 17% of families surveyed still don't have reliable internet or Wi-Fi at home, with families in Central California really experiencing the greatest disparities. And additionally, nearly 50% of families that we surveyed stated that they don't even know how to receive medical services online for their kids or by using the phone. And beyond the need to access reliable internet, having an email address is also something that's really important for families to be able to navigate our online digital world and also utilize telehealth in some cases. And so we asked also a question about parents and whether or not they had email addresses. And what we found was that statewide, 1 in families do not have an email address. And again, in Central California, the disparity was even greater, with about 1 in 3 who do not have an email address. Additionally, we partnered with an education advocacy organization called the Education Trust West to conduct another online survey, this time specifically focusing on families with young children under the age of 6. And in the survey, we again included several questions that asked about accessing health and mental health care utilizing telehealth. And what we found was that a slightly over a quarter, or 26% of parents said that they had not been able to access medical care using telehealth during the pandemic. But the vast majority of parents were really interested in being able to do so, with 94% of parents who agreed that accessing their child's doctor via telehealth could really help them and be beneficial for them. So seeing these equity and access issues from these surveys, we really wanted to get deeper into understanding specifically the experiences of families of color who have children with special health care needs around the utilization of telehealth to access care. Because we know that with surveys and data and numbers, they only tell a certain part of the story, but they don't tell the whole story. And so we really wanted to have the opportunity to directly connect with and understand the experiences of families. And so over this past summer, we convened 3 meetings with stakeholders in 3 different areas of California, including Pomona, Tulare, and San Bernardino. About half of these stakeholders were families of color with special health care needs. And during these convenings, we essentially had breakout groups where we split up the stakeholders and facilitated listening sessions specifically with those families to really understand the health and mental health needs of their children and the health needs of their communities, and then also how telehealth could be used to address those health and mental health needs. We also want to mention that we paid families with cash stipends for participating, for sharing their experiences. We really believe that we should be compensating families when we do engage with them. And so we did compensate families, and we also facilitated these listening sessions in Spanish, directly in Spanish with families, to really build the trusting relationship. And the vast majority of the families that we convened in these meetings were monolingual Spanish-speaking families. And so we're still analyzing all of the experiences and everything that we listened and heard from families now to create a policy agenda with recommendations that address those experiences and that also really come from families as well around telehealth policies. And so that brief will be coming out soon, in early next year. And although we don't now have any formal findings or report yet that synthesizes what we heard in the listening sessions, I do want to highlight a couple of things that have stood out for my facilitation and participation in these listening sessions with families. First, the families that we engaged with in these listening sessions, which again were mostly monolingual Spanish-speaking families of color with children who have special health care needs. One of the main things that many of them were telling us was that they had difficulty, specifically the parents and guardians, had difficulty navigating telehealth for their children, and weren't necessarily explained about how to navigate telehealth, what it is, what it's supposed to do. And so they often went back to their support groups for questions around telehealth and what it is and how to access it that were coming up from that for them. And so we really wanted to highlight this piece about how families really do need guidance. We all need guidance around telehealth, need guidance provided directly to them, like one-on-one with their providers around telehealth. They need more of that. Second, something else that came up frequently during these meetings was around language barriers and around how families who were utilizing telehealth, the parents specifically didn't necessarily have explanation of what telehealth was in their language. And so even though their children might have spoken English fluently to be able to connect with their provider in English, the parents didn't. And so the parents weren't able to really understand what was going on because they didn't have any information accessible to them in their language. And then finally, another piece that came up was the need for specialized care and the perception and the concern that telehealth can't be used to provide specialized care, and that virtual services may not always be appropriate. That also came up frequently with the families that we engaged with. So as I just finished highlighting, we've really been engaging families directly in telehealth policy advocacy through these listening sessions with families in regions across California. And I just wanted to close by outlining several reasons why it's really important to engage patients in telehealth policy research and advocacy, and really the benefit it brings to our collective work around telehealth. So first, including families really shifts power and shares power with them by centering people who have historically been left out of the policymaking that impacts their lives, their children, their families, and their communities. In this shift, community members then become the key actors in policymaking and advocacy by identifying their own experiences with telehealth and then becoming ideal partners for policy creation and implementation around telehealth. We also know that the biggest issues and barriers impacting children and families really change as social, political, and economic conditions change, and we should be responsive to those changes. And really, families understand these changes and challenges better than anyone. Second, engaging families and patients directly in telehealth policy research and advocacy really fosters civically engaged community members, and that increases the leadership skills that community members and families have in order to advocate for themselves and their children. And this also includes people who cannot engage in our democracy by voting, by example, because they are not citizens. And so whose preferences, ideas, or thoughts may not actually be reflected in our elected officials who are making policies because they didn't actually vote for them because they can't. And that's why it's also really important for us to include in these listening sessions immigrant families. And then finally, including family members in telehealth policy advocacy and research really fosters a structural and community competency among policymakers and decision makers in our state legislature, agencies, and health plans who are really creating these policies. These policymakers and decision makers are often using numbers or quantitative data to make decisions, but like I said earlier, numbers don't really tell the whole story. They don't necessarily tell us why certain communities are utilizing telehealth more frequently to access care more than others. However, through direct engagement, community members and families can really provide policymakers and decision makers with firsthand knowledge around their experiences, so that those experiences can then be reflected in the policies that impact them. So that's it for me. I appreciate you all for listening to my presentation, and I will stop sharing my screen. Thank you.
Thank you so much, Gabriella. Unfortunately, we are right at noon, and so we're not going to have time for questions right now. However, we just had a few, and we will go ahead and respond to those on Whova afterwards, so you can check back. Just a few final notes. Let's see. The session is going to end momentarily, and at noon, there's going to be a optional sort of meet and greet networking lunch that you can join by region. So go ahead and check for that if that's of interest to you. I'd like to again thank all of our sponsors. You can see who those are on Whova. And also a reminder that the sessions are recorded and you will be able to rewatch them after on the Whova app or website. And those Q&A will remain there as well. Please watch for your event evaluation in your inbox on Thursday. Your input really does help shape what we do for our summit, both when we go back to in-person and as we do virtual programming. So thank you all to all of our speakers and for all of you for attending this session.